I'm going to start by introducing you to two patients. First, we're going to meet Miss M. You know Miss M. She's an 80-year-old female who has advanced breast cancer. She was diagnosed 10 years ago, and she's showing up in your emergency department with shortness of breath. During the workup, you find that she has significant progression of her disease, pneumonia, and sepsis. And her vital signs do not look good, so you go to the bedside to talk to her and her family about goals of care. During that discussion, she says to you, "I'm tired. It's my time. I've lived a really good life, and I'm ready to go." You're like, "Oh, okay." You introduce the concept of hospice care to she and her family. They're super receptive. You call the local inpatient hospice. They have a bed. You discharge her there. On the way out the door, the family hugs you. They thank you. You call your friend that night and you say, "Oh, end-of-life cases are so rewarding. I want to go into palliative care." You've had this experience, I know you have, because you call me. People send me emails like this all the time, and I'm like, yeah, well, wait till you meet Mr. B. What do we think of her, right? She is brave, right? She's so stoic. She's so cool, Miss M. She's rational, right? She's accepting. She trusts us, right? And most importantly, she's just like me. She's just like me, right? She's exactly like I know I am going to be when I am in her situation. I can completely relate to her because we're just so similar. And then there's Mr. B, right? So Mr. B, he's 65 years old, and he has advanced renal cell carcinoma. He has had progression of his disease despite multiple rounds of chemotherapy, and actually when he presents, you look in the EMR, and you see that in his last oncology visit, they recommended hospice care. He declined, insisted on more chemo, and actually in the US, you actually just get to kind of choose whatever you want. So they said, okay, and they gave him more chemo, and now he is presenting 1 week after his last round, and he is neutropenic and febrile and multi-organ failure, septic shock. You're also very worried about him. And you go to the bedside because he's also not looking good. And he says, "I am a fighter, and I'm going to be fine. I will never give up because I am going to get a miracle. I know that there is going to be a cure for my disease." He insists on no limitations on life-sustaining treatment and insists on being full code. What do we think of him, be honest? Right? He's irrational. He's so irrational, right? He is clearly in denial. Can someone just hit him over the head with the reality of the situation? He is so frustrating. He's clearly desperate. And most importantly, he is nothing like me. I cannot relate to this guy, right? Let's take a survey. I'm old school. I'm not on social media, so I don't even know how to use all that polling thing that they're doing. Just raise your hand. I'm going to die like Miss M. Right? That's me. I'm going to die like Mr. B. No, yeah. I want to spend the last weeks of my life in a hospital with all of you good people. I am okay being on a ventilator in the ICU in the last weeks of my life. I want to die at home with my family, right? So I think we're all on the same page here. End of story. Let's go home, right? We all have very similar values and goals. So I'm not sure who in the room saw this essay when it was published in 2011, How Doctors Die. It's not like the rest of us, but it should be. So this was written by a retired family physician. And in it, he starts by introducing us to a friend of his named Charlie. And Charlie is an orthopedic surgeon who gets diagnosed with pancreatic cancer. Rather than undergoing surgery and chemo and radiation, Charlie closes down his practice, decides that he's just going to accept his diagnosis, focus on his quality of life. He goes home, lives for about 3 months at home, and then dies. And the author suggests that Charlie's end-of-life experience is really representative of how all doctors face the end of their life. He says what's unusual about them, meaning us, is not how much treatment they get, but how little. For all the time they spend fending off the death of others, they tend to be fairly serene when faced with death themselves. They know exactly what's going to happen, they know the choices, and they generally have access to any sort of medical care they could want. But they go gently. He also says, I cannot count the number of times that fellow physicians have told me, in words that vary only slightly, promise me if you ever find me like this, that you will kill me. And they mean it. Raise your hand if you've ever said those words. And the rest of you are lying. So this essay, did anyone see this essay or remember it when it came out? So it went viral. The media loved it. They loved it. It was like covered in all the major media outlets. The message was so simple and compelling, right? They had to just they just loved it. So, right, wisdom and intelligence and education, all of these qualities that us physicians possess, it turns out that these are actually the key to avoiding useless suffering and futile end-of-life care and wasteful healthcare spending. We are not vulnerable to delusions of immortality. We are smarter and we are better. And if only everybody else could be like us, everything that ails our healthcare system would simply vanish. This is about personality and morality and character and how it is these factors that determine how we face the end of our life. This argument is just so very American. So, as many of you in the room are aware, anecdotes, while they are so compelling and sweet, are often inaccurate and not representative of the larger truth. And it would turn out that this one was no different. So, this is something that you can actually study. And in 2016, a group of quiet little rebel researchers, one of whom I happen to know, actually looked at this. Now, full confession and disclosure, this is American, right? So I can only speak to the sort of American experience, but I have no reason to believe that you all are much different. Other than your accent, we seem very similar. So they looked at how do U.S. doctors die. So they looked at a cohort of Medicare decedents, and for those non-Americans in the room, we actually do have universal health care in the United States. You just have to be 65 years old to get it. So everyone gets universal health care at that point, and they looked at physicians and how much health care they used in the last 6 months of their life compared to non-physicians. And the results may or may not surprise you. So inpatient hospital use in the last 6 months of life was the same. Okay. Days in the hospital was also the same. Died in the hospital, also the same. Days in the ICU, also the same. So it turned out that physicians use hospice a little bit more, but there was actually a non-statistical trend towards them using everything a little bit more. And they were like, maybe physicians just know how to use resources really well. So this is not statistically significant, but it's funny. So I had to put it up there. And that is looking at specialties and how many days that you spend in the last 6 months of life. And emergency medicine, of course, the highest number. So there you go. What, right? How could this be? This is so disappointing and completely inconsistent with the narrative that I have grown so attached to, right? And that is that I am special and that I am different from my patients and that I'm better than my patients. And if anything, I'm like Miss M and I will never be Mr. B, right? So the authors have several suggestions, explanations for their findings. One very outrageous explanation is that we are, in fact, human, and that fear and avoidance of dying are strong motivators of human behavior, and perhaps, just perhaps, physicians are not immune to these fears of dying. So that is one explanation, but it is kind of mysterious, right? I mean, if you think about it, that essay kind of should be true even despite that, because we have such high health literacy. And that really should allow us to more carefully weigh the risks and benefits of treatments near the end of life and potentially avoid what we consider often to be futile care. But it turns out it's really not like personal morality and character and those kinds of things that drive the intensity of care at the end of life. So this figure here actually represents our current understanding of the different variables and forces at play and what determines the intensity of end-of-life care that any individual patient receives. And you'll see it's actually a bit complex, right? So regional, hospital and system factors, provider, family, patient factors, they all play a role, and they all play a role and interact with each other. And so you'll see health literacy, it's on that list. It's there. But it turns out if you live in an urban setting and there are a lot of tertiary care centers around you and a lot of ICUs and a lot of specialists, you're very likely to use them. And so if any of you in the room end up having a cancer diagnosis and a lot of functional limitations and poor family support and certain personality traits, and you live in an urban setting and you live near a lot of ICUs, it is very, very, very likely statistically or probable that you might end up exactly like Mr. B in my emergency department, about to be on a ventilator at the end of your life. And then we have to sort of shift gears for a minute and talk about this other very important issue that complicates decision-making near the end of life, particularly in the emergency department, where information is often incomplete. And that is the issue of prognostic uncertainty. Sure, it's really easy for people to see somebody die and then turn around and say, ugh, God, they got futile care, right? We hear that all the time. But what tools do I have when I'm in the emergency department and an elderly patient comes in and they're in respiratory distress and I've been with them for 20 minutes? What tools do I have to say, okay, I'm going to intubate this person and it's going to help them get back home, or this is going to be something that simply prolongs their dying, right? Nothing. I mean, I think if we're being honest, we rely on our experience, our judgment, and probably a little bit of bias when making those decisions. So I'm not sure who saw this study, Prognosis After ED Intubation to Inform Shared Decision-Making. It was just published last year, and it's honestly, I think, one of the first of its kind that I am aware of that's just trying to start to fill this information gap that we need. So they looked at 35,000 emergency department intubations and in geriatric patients, and they were looking at patient-centered outcomes. So who lived, who died, who got to the nursing home, who actually made it back home. And they represented their results in a way that actually might be useful at the bedside for patients and us. A lot of things jump out at me when I look at this data. One is you can see a lot of people die, and I think that's an important reminder to us that emergent intubations are terminal events for a lot of our patients. And as you can see, people are more likely to die as they get older, right? But something else jumped out at me when I saw this that actually surprised me, which I don't think was the intent of the authors, which was a sizable minority of very, very old patients actually do well. And that actually surprised me. I did not think that 14 or 15% of people age 85 to 90 who get intubated in the ED are going to actually just go home right after their hospitalization. That actually surprised me. And then you have this big chunk go into a nursing home, but in the United States, nursing homes are also used for short-term rehab, so I suspect a sizable minority of those patients eventually transition back home. What this data tells me is that while there are predictors of who will and will not do well with critical care interventions, there are few absolutes here, right? And so I think at this point in time, we need to be careful with our judgment and our certainty. So I think it cannot be denied that when we meet the Miss M's of the world, we are inspired to see that kind of calm and that kind of courage in the face of death is deeply moving, and I think there's nothing wrong with that. But what do we do when we meet the Mr. B's, right? So when I find myself up on the pedestal, shaking my head in frustration, I think often, probably on a weekly basis, of the words of Stephen Jay Gould. He was a famous biologist who was diagnosed with mesothelioma at a young age and was told that he was going to die and completely rejected that idea and did his own research. And he wrote an incredible piece called "The Median Isn't the Message," and I think about it often when I come across Mr. B. He tells us It has become, in my view, a bit too trendy to regard the acceptance of death as something tantamount to intrinsic dignity. He says, and he goes on to say, when it's my time, I'll deal with it and I'll face it. But for most situations, I prefer the more martial view, that death is the ultimate enemy, and I find nothing reproachable in those who rage mightily against the dying of the light. And it helps me, at least, come back to earth. And then I would say the other thing is, I actually think it's actually a strength, knowing that, in fact, we are just as vulnerable as our patients, right? We are just as vulnerable to the same fears, the same hopes, and maybe even the same hopes for a miracle. I think that's actually a strength, and that can be a vehicle for more compassion at the bedside. One of my heroes, Brian Stevenson, who wrote Just Mercy, he talks about the fact that we are all broken. We are all imperfect, and that brokenness is something that we all share. But he also says that our brokenness is the source of our common humanity, the basis of our shared search for comfort, meaning, and healing, and that our shared vulnerability and imperfection nurtures and sustains our capacity for compassion. So, how do we translate this at the bedside? I don't want the takeaway to be, we can never know how people are going to do, and we don't want them to feel judged, so let's go back to the days when we just asked them what they wanted and did everything. I don't want that to be the message. I think we still have a critical role to play at the bedside in guiding patients and families through what can be incredibly complex and overwhelming decision-making at the end of life. I would just say that we should offer that guidance, but I think maybe sometimes balance it with a little bit of humility. And I also think that when I find myself sort of feeling like something that the patient wants is inappropriate and wanting to hold it back and there's some conflict there, I think I personally could do a better job of acknowledging that there's probably a little bit more uncertainty there than I'm willing to admit. And the last thing I will say, and I hate to be a Debbie Downer because we're having such a good time here, but we are all going to have the opportunity to be at the end of life one day. And I think that we will all want to be the doctor. We should all be the doctor that we will want when we're in that situation. And I know for me personally, if I have the misfortune of having a cancer diagnosis and I end up in your ICU or your emergency department, I will be counting on your medical expertise, and I will want your guidance. I will be hoping for your acceptance and your compassion, but I am 100% certain that I do not want your judgment for any of the decisions or crazy decisions that I end up making about my own care. Thank you.